It's a privilege to be part of this symposium, which is really fabulous in its range. Can you hear me, first of all? Yes. In its full range of basic science through more clinical work, and you will see that I am definitely on the clinical end of the spectrum. So we're going to be switching from rodents and macaques to humans, trying to think more together about how we can think about the impact of loss and a syndrome of complicated grief. And I will pose to you that one conceptualization of complicated grief is as a post-loss stress disorder. So these are my disclosures, largely research funding grants. So the learning objectives for this conference will really be threefold: to understand support for complicated grief as a condition or diagnosis, to recognize complicated grief within the spectrum of trauma and stress-related conditions, as well as understanding its common comorbidities with mood and anxiety conditions, and then to share with you and identify the evidence base that's currently available to support psychotherapy and medication treatment approaches to complicated grief. And I'm going to be sharing with you the results of a multi-center trial that is not yet published, but recently in press. So really, just to start, first of all, I want to acknowledge Dr. Catherine Shear, who some in the audience have worked with as well, who really brought me into this area with a background in anxiety and trauma myself. I've been doing this for about 10, 15 years, and she really showed me that loss is a major stressor, and actually one of the most distressing experiences that all people experience throughout their lifetime, because it really impacts every aspect of a person's life. And really, a way to think of this is that it's a combination of a trauma response along with an attachment or separation response, and I will share more information about how we think about that in a moment. So this is actually a slide from Dr. Shear, where she was very interested in the relationship that was formed between this hound and this orangutan, but really in light of sharing with all of you that you can use attachment theory to understand complicated grief. So there is trauma and mood-related aspects of it, but attachment is really important to understand as we think about the impact of loss. So in attachment theory, the idea is that there's an underlying biological motivation for close relationships. We heard this morning about attachment and about early life impact on development and critical developmental periods, that neural networks will guide and form the development of these kinds of relationships and attachment, and that attachment really provides for a person a safe haven and a secure base from which to go out and explore the world. So that's kind of a basic conceptualization. If you understand that, you can use that to think about the impact of loss, because attachment is so tied into our motivational systems around exploring the world, caring for others, and feeling safe in the world. So when you undergo a significant loss and are in a state of bereavement, there is, brought on through that, a sense of attachment insecurity. So that tight, safe haven is removed. It can be suddenly or actually really even when it's expected. You have people who are equally impacted by that. And this can activate a number of different types of reactions. And this is not a disorder. This is just in that acute bereavement period. There is proximity seeking, so there's kind of a yearning and a longing, initially not really wanting to accept that the person is dead, insistent thoughts and memories about the person, and a wide range of biological, psychobiological dysregulation with sleep disturbance, loss of appetite, and so forth, that all can be within the norm of an acute grief reaction. During that period, it's hard to think about other things. People often will stop working for a period of time or may need others to help care for them. They may feel incompetent in their day-to-day activities, and also have a sense of kind of having been ineffective as a caregiver themselves, even when there is no evidence to that effect that the death had anything to do with that, but there's a sense of kind of incompetence around caregiving. There can be self-blame, anger, remorse, and so forth in that initial period that needs to kind of progress through. So a model of thinking about how we get to complicated grief is really to understand the natural pathway of a bereavement through acute grief to a more integrated form of grief. And I think, without spending a lot of time on this in our relatively brief talk today, the field has developed and learned a lot that there's not one clear pathway to integrated grief, and there are not necessarily one clear stage that comes after the other, but nonetheless there is a kind of piece of work that needs to be accomplished for someone to move from that initial acute grief state to having grief be more in the background instead of in the front of the brain. You might think of really a few key components that are being worked through here. So the traumatic distress component, separation distress, caregiver self-blame, and then this kind of shutdown of going back out into the world. You need to move past these through having a kind of an effective regulation of emotions, being able to tolerate one's emotions, really learning that the death is final so that you're no longer seeking the person and can kind of integrate that the person is not returning, and being able to really make what for some people is a huge shift in what they're just doing in their day-to-day activities and their life goals. And we see this especially in people who have been caregivers of patients with cancer. So spouses who may have had that be their entire job. So they did not just lose that attachment, but they lost their job and role in the world. So they have enormous shifts and transitions to need to make to be able to work towards kind of a new and satisfying life without the deceased person, with the goal of having not zero grief. So we have many patients who come and say, why do you want me to have zero grief? We don't say we don't want you to have zero grief. We want you to be able to return to a satisfying life where grief is not everything in your life, and it can be more in the background, and it can flow in and out with bittersweet memories that may be accessible and can change. And actually really what we find as people do the work in complicated grief is not that they don't remember the person anymore, they actually access those memories much more, as opposed to being stuck really predominantly in the time of the death, which is what we see in patients who don't work through here. So this is just some data from George Bonanno. It's older data, really just showing that after loss there are variable patterns of recovery. And here you can see that the most common is actually resilience, so that people may have an initial blip over here of acute grief, and then that kind of comes down pretty quickly. You'll have a very small number who get more of a delayed response. The most common are these recovery and resilience, and then this group at the top, which is the chronic, and the 5 to 30%, I would say, are within those our population who develop a more persistent or complicated grief. The best epidemiologic data we have by Kirsten and colleagues is that after bereavement, about 7% of people will go on to develop complicated grief. People have used either 6 months or 12 months as the timeline from which you can define this. I'll tell you a bit more about it. In our research, we have tended to use 6 months. The current DSM proposed diagnostic criteria use 12, but I think it's important to realize that bereavement, like other types of traumas, is a major life stressor, like other stressors, and not everyone goes on to develop complicated grief who runs into trouble. That there are other types of stress-related responses and conditions, including depression, post-traumatic stress, substance use disorders, and other types of psychiatric or medical responses to that enormous stressor of loss. So this is just the simple way of saying that complicated grief is really an unusually persistent form of what I described to you as that initial acute grief response, and typically there are maladaptive thoughts or behaviors that sustain the complicated grief and really interrupt what would be those normal adaptive processes. So this is a more kind of detailed way of thinking about what complicated grief is, but basically the concept that acute grief does not progress and that there are likely reasons for this. A large component of this is that information about the death may not be processed, so people may be stuck in a state of rumination about the meaning or details around the death itself. That includes self-blame or responsibility for the death, even when it is very, very clear. We have patients come in who are absolutely convinced that even though they were caring for their significant other who was in the hospital, the fact that they went out for a cup of coffee and at that moment their loved one passed away, if they had only been there, that would have prevented the death. And there, even if there was something in that moment, there's no ability to think about any other explanation than ownership for responsibility for the death. So we can see this, the point is, regardless of the type of loss, some people get stuck in this situation. So I'm not sure why this one stopped. Sort of lost the thing. I can do it up from here. Can we get this to go back? I lost the screen here. There we go. Whoops. Let me go back. Okay, so other things that would interfere with it are avoidance, and then coming to the table with poor emotion regulation skills can also be contributors to persistent and difficult kind of incorporation of the acute grief symptoms. So complicated grief, really we think of as having some kind of complicated problems around that kind of interpretation, understanding of the loss and moving forward. Key kinds of symptoms include the intense yearning, longing, despairing sadness, other kinds of troubling emotions like anger, preoccupation with thoughts and memories of the deceased, and the intense reactivity to reminders. So some things that sound very overlapping with post-traumatic stress, while others are more on that separation anxiety distress, and then some things that overlap with more of a depressive presentation around feeling life has no purpose or meaning, having trouble achieving joy or satisfaction without the deceased person. And so I put to you that we can think about complicated grief as a post-loss stress disorder. Really, there are only other conditions that we have in psychiatry that come with an initial clear stressor are adjustment disorders and post-traumatic stress disorder. This is another event-linked response, which there is a normal initial response and then a persistence. And it's really just a subset of people. So most people, even though this is a major life stressors, do successfully move past that over different periods of time, some of which is actually culturally sanctioned, right? There are differences cross-culturally in how long someone is sort of expected to be in a more acute mourning period. But a number of different people have proposed, even as early as 1997, Horowitz, that complicated grief should be in DSM as a stress response condition, and then a little bit later, Langner and Merker in 2005 described complicated grief as a stress response, really focusing on the core symptoms of intrusions, avoidance, and failure to adapt. So really that's a simple way of thinking about complicated grief as difficulty adapting or resolving those acute responses to the loss. So in DSM, without going into huge detail, while complicated grief did not make it into the diagnostic criteria, and I should probably just take a second to say that there's a number of different terms that are used for this in literature, from prolonged grief, persistent grief, traumatic grief. Traumatic grief, I think people felt was confusing because the loss, as I mentioned, doesn't have to be a trauma in the sense of an acute and sudden death. It can be an expected loss or aging or anything. And then I think as a compromise, in DSM they used a name that was appearing nowhere in literature and no one had ever heard of before, which is persistent complex bereavement disorder. So it's unclear if that will stick, but I find it's a lot longer to say. We have felt that complicated grief is just to leave it there, a nice way of putting in that concept that the grief process is complicated by something, and that in the work we do clinically, particularly in psychotherapy, we think about what are the complications that may be keeping that person stuck in more of an acute grief type state. So anyway, it is in there as a disorder under consideration. One thing that was actually a big area of debate is whether there should be multiple different kind of equivalent of the one anchor criteria. Most patients have persistent yearning and longing for the deceased, but not all of them. So there's a minority in studies of maybe 10 to 15, 10 to 20% who may not have that as the prominent feature, and there still can be complications around that death being the main focus of the person's distress. So that can include intense sorrow or emotional pain, preoccupation with the deceased person, and then very commonly preoccupation, as I was mentioning, just a simple example of the circumstances of the death itself. So this can be around the last words that were said with the person, how the person died, not knowing how the person died, and spending a lot of ruminatory time envisioning that and so forth. And then in order to make the diagnosis in DSM, you have to have at least 6 of reactive distress reactivities. That can include difficulty accepting the death. Some of these, again, similar with PTSD, feeling shocked, stunned or emotionally numb about the loss. Difficulty with, as I mentioned, the positive reminiscing, so that's something that we can get back with treatment, is pulling in the more full, the negative and the positive memories. Bitterness or anger related to the loss, maladaptive appraisals about oneself, so the self-blame, and then excessive avoidance. So again, overlapping with our stress response types of conditions. This is a simple scale that I put up here that is a self-rated scale. You can use this scale. This is just a summary of the main items, but a lot of the work has been done with this scale, so I just wanted you to quickly see what some of the items are on it. It's 19 questions, so the patients can fill it out pretty quickly. Some studies have used 25 as a cut point for clinically significant symptoms. We have tended to use 30. Particularly because we're working in a clinical setting where we're doing interventions. So we wanted to assure that we have a kind of clinically significant level of complicated grief, but it's something patients can do very quickly in practice. I use it in my clinic as well, just to monitor how folks are doing over time. So I did a project with Kathy Shear and others looking at 782 individuals who were bereaved and completed this form. They didn't necessarily have complicated grief, but we wanted to look at the factor structure and components of the inventory of complicated grief and grief symptoms, and they fell out into the yearning and preoccupation, anger and bitterness, shock and disbelief, the avoidance and proximity, estrangement from others, and then there was a very small, and this is just kind of a couple questions in there, that's not very common, the hallucinations of the deceased. And then Kathy Shear developed a structural clinical interview for complicated grief that we've been using across our studies. It's a SCID-like module to assess the different components, and so we did a similar kind of factor analysis, and again it broke out, this time I think including some things that weren't clearly present in the ICG. I don't think it captures exactly everything, but here are the key components that I've been talking about. So yearning and emotional pain hang together, difficulty accepting the death, emotional numbness, loneliness, or disconnection from others, suicidal ideation and meaninglessness. So this is a high-risk population, I think, without having too much time to go into this, that particularly in the first year after death, there's a big bump in risk for suicide. So we see high rates of suicidal ideation in clinically complicated grief population. And then the final being the avoidance and negative affects. So the question is complicated grief really a separate thing? Like, should we add another diagnosis to psychiatry? There's so many diagnoses. DSM is now, too heavy for anyone to lift. So we wanted to look at this, like, are there patients who come in with CG alone, or how is this interacting with its nearest neighbors, which are depression, as I've been talking about, and post-traumatic stress disorder. So this was the first study that we did of this, and this is a treatment-seeking sample who came in saying that their main primary problem was the grief, and you can see that about a third had no other diagnosis, but equal or slightly higher amount had all three: major depression, post-traumatic stress disorder, and complicated grief. And then there were smaller subsets that had complicated grief and depression, or complicated grief and PTSD. So clearly, as we think in the world of kind of RDoC, or how do things go together in symptom risk factors and syndromes, these are along a spectrum, and there's likely overlapping risk between them as we think about the different components of these disorders. So another thing that is looks to be at least in early data, some work that we did this is a retrospective assessment of dissociation around the time of the death. So given all of the limitations of asking this question in a sample that already has difficulties with the grief, you could see that severity was associated with greater dissociation around the time of the loss. So there may be some, this is really just to say that there may be many overlapping risk factors with patients who develop PTSD. This is also just a look that I did a couple of years ago at the data trying to understand the PTSD type symptoms. So we had patients with complicated grief fill out the Davidson trauma scale. And then I was interested to ask the question, like, does it matter the nature of the type of the death, and does that affect the type of traumatic symptoms or severity of traumatic symptoms that patients present with? And first of all, it turned out that we gave the patients the opportunity to write in what was the most significant trauma, and they all wrote the death for the complicated grief patients. And it really didn't matter what the type of loss was. So whether it was suicide or prolonged illness that one might think they would have expected the death, there was a similar amount of traumatic distress after the death. Go to the next slide. Here we go. Okay, so then thinking that there are likely overlapping risk factors of possibly premorbid, but certainly concomitant mood or anxiety disorders. In my work, I had the privilege to work in many different types of mood and anxiety populations. So I was able to gather data looking with the inventory of complicated grief at samples of patients who come in with different types of conditions. And I'm going to show you some of that, because really I would put to you that, like in PTSD, pre-existing mood and anxiety disorders of any type are likely a risk factor for developing complicated grief after a death. So you'll see a certain pattern here. Is the first study that we did looking in major depressive disorder, and about 1 in 4 had complicated grief amongst those who were bereaved compared to control sample of bereaved patients. Similarly, I was able to look in a sample of bipolar patients who participated in the STEP-BD clinical trial. So these were treatment-seeking patients who came into clinics around the country. We were able to access 120 of those who participated in Boston, who completed assessments. 86% reported having lost a loved one, and again, about 1 in 4 met criteria for complicated grief who had had a loss. And then interestingly, you could see the increasing kind of comorbidity association with suicide attempts. So I think I like to just make this point, because I don't think people very commonly in clinical settings screen or identify complicated grief, and yet it is actually a very strong risk factor for suicide risk. So here we asked patients their lifetime history of suicide attempts. So it was pretty high as a bipolar sample with a lot of comorbidity, 33% with no lifetime history of panic or CG. If you had complicated grief without panic, it was 53%, but if you had that combination of severe anxiety and complicated grief, fully 70% had made a lifetime suicide attempt. So really just to keep in mind that this is a risk factor for suicidal behaviors. So this is repeating again, looking at different samples now across different kinds of anxiety disorders, PTSD being the most like the depression or bipolar samples of equivalent risk. So about 1 in 4 who reported having been exposed to a lifetime loss, meeting criteria symptom level of clinically significant complicated grief symptoms, and higher than controls for panic, generalized anxiety, and then social anxiety disorder. But clearly it's the panic and PTSD spectrum, so the more intense kind of anxiety and emotion dysregulation type symptoms based disorders that were higher risk. So this is just, we're actually doing a second look at a larger sample, but this is just some naturalistic data from the Home Base program, which is a philanthropically supported program at MGH. It's our outpatient clinic for post 9/11 era veterans. focusing on PTSD and related conditions. So we just had them, as part of their clinical care, fill out a number of assessments at baseline. And here again, we saw 1 in 4 meeting criteria for complicated grief who had reported the loss of a significant other of any type or any type of relation. Here we were interested in whether there was a greater, and this was really an understudied naturalistic look, a greater impact of loss of a fellow service member, and you can see it was 38% versus 21%. I actually don't have a slide on this. We're just finishing the analyses actually from a randomized controlled trial. They were doing a PTSD with Sheila Rausch and others, and we actually replicate that with significance and a little bit even broader difference of about, I think it's 43% versus 19% with a greater impact of a loss of a service member. And those are in patients, the other study is in patients who have a primary combat-related PTSD. So again, I think just really making the point that complicated grief is really prominent and often not asked about in clinical settings, and yet has a major impact. So, and clearly hangs with PTSD. So in our own clinic, it was much more common in patients who also met criteria for PTSD. So what are some of the Cg risk factors? I've really talked about some of this. So prior psychiatric conditions, childhood, you heard about the impact of childhood trauma and early loss in development. Women are also, at least in the studies that are available, to the extent that they are at greater risk in epidemiologic studies. Older age, although there is a greater cumulative burden of loss as people age, so it's a little bit confounded by that. And then the attachment and relationship variables that we talked about. I showed you some of the data on the dissociative responses, but I think it's also when there are circumstances that interfere with that processing of the loss, those may also be risk factors for going on to develop PTSD. So if you are in a disaster setting and you're not able to really process what was going on at the moment, or you don't have information about the death and you don't never get that information about the death, these are things where people may get psychologically stuck or ruminate that we end up working with them in therapy on. And then avoidance as coping strategies, trouble tolerating emotions in general, and then of course the use of alcohol or substances. And we think similar to many of our conditions, low social support, when you have a loss, naturally across many different cultures, we bring our loved ones around us to help us to get through that acute period. So many of our traditions, religious and cultural traditions, enhance social support. So for people for whom there is no social support, they can be particularly at risk, and actually particularly at risk for suicide as well, that group. We definitely need a lot more data on biology. I felt, given this conference was called the Amygdala Conference, even though I didn't have any amygdala data, I should at least briefly mention a couple of biomarkers. There's not a lot of work, particularly in diagnosed complicated grief samples. This is some work from Mary Frances O'Connor, and she actually was looking at the nucleus accumbens with the idea that the reward pathways may also be involved in the longing and persistent yearning that goes on in persistent grief. And she did a experiment using grief-related versus neutral words, and did show differential activation in the nucleus accumbens. So that's one small sign that we have in complicated grief. This is another study by Perez and colleagues where they were able to also show that there's significant impact on cognition with 3 different neuropsych tasks and slightly lower mini mental state scores as well. And then there was a study just looking with MRI. And again, I think this is a very gross thing to show to this population in a neuroscience symposium, but they reported lower total brain volume. And I think, again, this is, and this actually went on a spectrum from complicated grief to bereaved but without complicated grief symptom load, and then non-bereaved. So I think it's really just suggesting again that we can think about complicated grief as having chronic stress related downstream effects in biology is how I would interpret that. So overall, in summary, just as a condition, so we can have enough time to talk about the treatments, complicated grief associated with functional impairment. There have been data with death and complicated grief associated with increased cardiovascular illness, but we're going to hear a lot more about stress and cardiovascular illness, I believe, later. High-risk behaviors, sleep disturbance, poor quality of life, and then some data showing as much as 8 times increased risk for suicide after controlling for depression and PTSD. So the question is, when do we intervene? Because this is a natural process. Everyone is going to be exposed to an important death at some time in their life, and not everyone needs to come in for treatment. So if you're a clinician, how do we think about when to intervene? So I think the thing is that we want to screen for symptom severity. You can use things like the inventory of complicated grief to track that load. You may see that even in the early period and see it start to come down. We want to encourage people in that early period to get out and re-engage in activities, re-engage with others, not isolate themselves, and get back out there. For folks who can't, so they are not progressing, and you're seeing them over time, and it just, every time it seems like it just happened yesterday. That's our complicated grief subgroup generally that we have in the clinic where we want to be intervening. And certainly if they come in with suicidal ideation or hopelessness or those acute risk factors, we don't want to wait till they get whatever DSM says. We don't want to wait till 6 or 12 months to start intervening if they're at risk for killing themselves. So those are the times we want to kind of think clinically about when to intervene. This is just to take you a very quick overview. Some of this was before and some of this is after we did our clinical trial, but there's really a very small amount of pharmacotherapy data at all in complicated grief. All of it were these small open trials, promising but really very much influenced by the fact that they're open label without controls, so you would naturalistically see change with treatment over time. They were with 2 different SSRIs. But this was some of the background that led us to be thinking about working with medication and complicated grief, and then also just the overlaps with depression and PTSD. These are growing data of different types of, without going into great detail, different types of structured cognitive behavioral therapies. What you start to see, they're all small trials. A few are now randomized or with waitlist. A couple are with internet. What we're starting to see is having some type of exposure. And this is not a fear-based exposure, but the concept is a processing of the loss. So telling that story of the death, though, around that time period is one of the active components of the psychotherapies. So there's growing data, and some of it, again, is before. Some of it is similar to what Kathy Shear developed, but mostly what we have worked with and where there's the most data is with something called complicated grief therapy. This complicated grief treatment is a 16-session psychotherapy, one-on-one protocol, and it pulls different strategies that are cognitive, behavioral, working with the interpersonal relationship theory, as well as some motivational interviewing. So the simple way of thinking about it, the major premise of what complicated grief therapy does, is that we try to release and facilitate that natural adaptive process. So to find where is the person stuck, how do we focus on that so they can go back to their normal adaptation, and what might be interfering with that. So this is a way of thinking about it. Again, this is Kathy Shear, that's Kathy Shear's therapy. We think about it that we want to resolve those complicating problems that are blocking acute grief from going through the process to integrative grief, and then we want to also facilitate adaptation very directly by helping the patient to re-engage in life without the deceased person and be able to achieve those major transitions that need to occur both psychologically but also practically in life. So to date, there are now 2, before our study, there were 2 large randomized controlled trials. The first one being done in a general adult population, the second one in an older adult population that compared to interpersonal therapy for loss. So that's Myrna Weissman and colleagues, very successful depression treatment. And here using a responder definition of a CGI of 1 or 2. In the first study, 50% achieved response, and the second, 70% achieved response. So I did some work with Kathy Shear trying to understand. In her first study, they naturalistically allowed patients to come in who were already taking medication. So I was very interested in what the effect of that medication might be. And we broke it out into 2 groups, so the groups that were taking antidepressants and the group that were taking benzodiazepines. And in green, you can see that patients, you might think, so in psychiatry, we often think patients who haven't responded to one medication or one intervention, they're actually going to be harder to treat because because they are treatment refractory by nature. So some people would respond to anything you do the first thing. But actually in this case, the patients who came in on an antidepressant did better, significantly better. And that was true for IPT or complicated grief therapy, except the major difference was that many, many more people dropped out who were not on an antidepressant compared to 91% completing who were with complicated grief therapy. And this effect was not present for IPT, making us think there was something that maybe enabled people to tolerate the hard work of complicated grief therapy better if they had antidepressant on board. And then interestingly, we saw not significant, but the opposite effect in benzodiazepines, where people did a little bit worse, which is kind of consistent with what we understand about benzodiazepines interfering with extinction learning as well. So we thought it might be specific to serotonin and antidepressants, so we designed this study, which is basically a 4-arm study comparing citalopram, so an SSRI antidepressant alone. So clinical management is just the general kind of assessment and working through with the patients to manage suicidality or other types of things, versus placebo. And then the other half got the medication, so everyone took a pill. The other half got complicated grief therapy and a medication. So it's basically a 2-by-2 design. Everyone has either pill placebo or active citalopram, and then half have the complicated grief therapy. And then we also received some additional funding from the American Foundation for Suicide Prevention to focus on individuals specifically with suicide bereavement to see how they would do. This is a broad age range, 18 to 95 were eligible. We used that 30 on the ICG, and they had to have grief as the most important problem. We had relatively minimal exclusion criteria, though we did exclude current substance use, psychotic disorders, dementia, or bipolar. We used a MoCA for just cognitive capacity, but we set it at 21, so they could have some mild cognitive issues. And they couldn't be at acute danger. They could have suicidal ideation but not be requiring hospitalization. And then because we were testing these things, we didn't want them to have had them before or be pregnant. In general, we had a somewhat older population, so this is who participated, 395 individuals with a mean age of 53. They were 78% female, so many more women who came in seeking treatment with us. We had a range of races, though predominantly Caucasian. And these were the types of losses that people came in with as their primary loss. So people could have more than one loss, but they had to choose the primary loss that we would be focusing on. And fully a third, it was a partner who had died. Almost 1 in 4, it was actually a parent who had died, and this was not a child, so somebody who was 18 or older. For some people, it was a child loss, like so when they were a child, they lost their parent. For others, it was an older adult loss. For others, they were actually older caretakers of a parent who died. So there's a full range. And then 1 in 5 had lost a child, which is a particularly difficult type of loss to treat, it turns out. And it was more actually not an issue around achieving that 6 months, because the mean time since the loss was actually 5 years, and we had quite a broad range of time since the loss in the population. And violent, this is probably not the right word, but about 1 in 3 had either an accident, homicide, or suicide loss. And we did have high rates of comorbidity with depression. Actually, 2/3 met current depression criteria. Maybe because we were kind of advertising with the medication, we got an even higher rate of people with depression, and 39% had PTSD. That's just the range of CGI severity scores. And then I think it's important to note that in this population that more than half had had some kind of suicidal ideation since the death. So again, very high risk factor for suicidal ideation, it was wish to be dead, and then active suicidal thoughts was like having more active, like I'm going to do something about it, was in 1 in 4. We did have dropout from the trials, greatest in the pill placebo alone group, about 2/3, 60 to 75% in the other groups. But basically overall we had greater dropout in pill alone. And one of the things we're starting to look at more is kind of the acceptability of complicated grief therapy was higher than medication, and certainly medication alone. So these are the main outcome results. One thing I should say is it's kind of a unique design, in part because of issues that came up with safety of citalopram. We set the endpoint to look at for citalopram alone at 12 weeks. We didn't want to keep people for 20 weeks on an inactive medication and no other treatment who had suicidal ideation and so forth. So we looked at our first outcomes for citalopram alone at 12 weeks. Here you can see there's a slight difference in response rates, again using this CGI, so the clinician global improvement score of 1 or 2, which is much or very much improved. Really no difference at all on this measure at week 20, which was the outcome for complicated grief therapy, so that they couldn't get all 16 weeks of the therapy in, between whether they had citalopram or not. But I think the real story here again is this is really 4 groups, and what you can see is that the complicated grief therapy was actually carrying most of the weight of the effect and had a significantly greater effect, whether it was compared to placebo, with placebo, or compared to active citalopram with citalopram. And then these are some of the results looking at the impact on suicidal thinking in the population. And you can see again that with complicated grief therapy, we had a significant reduction from that 1 in 4 to only 7% still reporting on complicated grief therapy alone. Any type of suicidal ideation, similarly in the combined group, down to 4%. We did not get that effect with medication alone. So at the end of the study, we had a small drop, but not a significant drop. Many more who were still suicidal at the end of the study. So overall, just sort of fitting in within the time frame, really this is just a story I've told you today, is that complicated grief has some overlaps with trauma and with depression, but we can think of it as kind of a post-loss chronic stress condition in which there is a failure to adapt or some type of complication that interferes with the natural adaptation and healing process that goes on in moving from acute grief to a more integrated state of grief. And that, like PTSD, there are some overlapping risk factors, so early life trauma, pre-existing losses, difficulties with emotion regulation, particular difficult circumstances around the loss or the type of loss, like loss of a child being particularly difficult, the nature of the death itself, so being very unexpected, and that CG is highly comorbid with its closest neighbors of PTSD and depression. But the key differences are really having to integrate attachment and separation distress. So if you can think of traumatic distress alongside attachment and separation distress, those are the 2 things that contribute to complicated grief and that we try to address in treatment. So in complicated grief therapy, which I didn't speak too much to, what we really try to do is focus on both of those elements. So we're working with the patients. They tell the story of the death. It's not exposure from a fear extinction type of way of thinking about it, but an emotional processing and acceptance and understanding the story of that loss and being able to move forward beyond that. So we do give them homework as well for exposure to reminders, because many patients with complicated grief, in their avoidance, they may avoid many aspects that are what brought them pleasure. So you can think about if somebody was part of a couple and you did everything together, and now you're going to avoid basically all of your friends and activities because they're going to remind you of that loss, and that's absolutely too triggering. So part of what we do is we create a hierarchy of getting people back into things that they're avoiding, not really to pick the thing that would be most distressing, but to pick things that would be triggering, which they can ultimately get back into having a life without the person present. So there are those components, and then we also work with folks to try and envision for themselves things that would bring joy, meaning, and pleasure. It's very much of an active like homework assignments of working on track to develop kind of goals and purpose in life. So really coming up with something that would be for themselves that they can do going forward in the world. So it's kind of a processing the loss track and a moving back into life track in the complicated grief therapy. And we know that this kind of work, so working on the adaptation and the emotional processing, is effective now in 3 different randomized controlled trials. And in terms of medication, which is slightly cut off, we definitely are in our infancy of work here, and there's really very little to kind of think about, should we be using medication maybe earlier on that would help people to be able to more effectively process that experience and the loss if they're developing depression and PTSD and other types of associated things. But there's a lot more work needed in that area. So with that, seeing that I'm just over, I'm going to go ahead and stop. But thank you very much for your attention.